I'm taking my time for you. I'm taking my time because he hates this picture.
That is a truly awful. Okay, it's gone. Thank you. That is a truly awful photo of me. It was taken 2 years ago. I just look so chubby in that photo. I look like I ate the 2024 version of me. I was just so chubby. But anyway, thank you, Barry, for your presentation on NHI. I'm just going to be extending the talk on NHI, but just extending it to Africa, discussing how universal healthcare coverage is like in Africa, the progress that we are making towards achieving universal healthcare coverage, the challenges that we are facing. As you guys know, there are some countries in Africa that have got some NHI system. So I'm going to be discussing their NHI systems, the challenges that they are experiencing, their successes, and what we can learn from our brothers and sisters across Africa who are trying to achieve universal healthcare, what we can take from them as we are trying to implement our NHI system. So first I'm going to just give a brief overview on the universal healthcare coverage as it stands right now. So currently as it stands in Africa, there's a low proportion of people that have got coverage to essential healthcare services. If you look at this map here, it shows the proportion of people in each country in Africa that have got access to essential healthcare services. There are very few countries in Africa where more than 50% of the population have got coverage to basic healthcare services. Most countries, the average proportion of people that have got access to these services is sitting at 30 to 35%. There are some countries that are even floating at between 15 and 25%. This is a very scary image. It becomes even more terrifying when you look at it on a global scale. So we've got a very low you've got a very low proportion of people that have got access to essential healthcare services, especially when you compare it to the rest of the world. Just compare the rest of the world. Many countries, on average, 80% of their population have got access to basic healthcare services. But there are reasons, like the reason why Africa is so far behind in comparison to the rest of the world. It's not due to a lack of effort. It's because we are faced with many challenges. Africa faces many challenges in its pursuit of universal healthcare coverage. We are a very unique continent. We have got centuries and centuries of hardship and struggles that are affecting us till this day as we are trying to achieve some sort of universal healthcare coverage. These challenges include a lack of healthcare facilities, high disease burden, lack of medical staff. We're a continent that has suffered from a lot of political instability and civil war. Massive financial crisis that we are dealt with. A lot of African countries are in extreme levels of debt. It's very difficult to build a healthcare system if you don't have enough financing to invest in your healthcare sector. Recent times has been very dark for the African continent. We've experienced really dark times that have affected us, that have been a huge variable in us trying to achieve any form of universal healthcare coverage. However, there are countries in Africa that have got some sort of formal policies in trying to achieve universal healthcare coverage. There are a few countries that have got NHI, but for the purposes of this presentation, I'm just going to be talking about Ghana, Rwanda, their NHI systems. The reason I chose these two countries is because they've got over 2 decades worth of experience of implementing NHI. These are two countries that we could learn a lot from. They've got 2 decades worth of experience. So I will be touching on these 2 countries here. The first one I'm going to be talking about is Ghana. So how does the healthcare system in Ghana work? So historically, Ghana had a cash and carry system from about 1972 2000. They had a cash and carry system. What is a cash and carry system? So a cash and carry system, it's crazy to think about now, but when you go for during that period, when you go for healthcare treatment in Ghana, you have to pay up front before you receive treatment. Now, that is scary. Upfront, like imagine you're going for an emergency and they're not going to service you before you pay upfront. That's not sustainable. So in around about the 2000, they had to abolish this. As the new president was coming into power, he promised citizens an NHI system. He promised to abolish this cash and carry system and implement a national health insurance. It was first piloted in 2000, but it became into law in 2003. Now, 70% of the population is covered by national health insurance schemes. National health insurance schemes, which originated in 2003, as I've mentioned, is an umbrella term for 3 different types of health insurance schemes. So these health insurance schemes are, so NHI is comprised of 3 main forms of health insurance. Private commercial health insurance, so these are your, as in the name says, private health insurance. These would be your Liberties of the world, your Prudential Healths of the world. And then you get your private mutual health insurance schemes. These are more for your government employees, your public servants. So this, oh, sorry, I'm in your way there. So these would be your private mutual insurance would be like your gems of the world. This is mainly for your public servants. And then they've got another one, which is called your district mutual health insurance. This is their NHI. So in Ghana, when they talk about NHI, they are referring to district mutual health insurance schemes. As of 2021, 54% of the population is covered by this district mutual health insurance, which is quite scary. So 70% of this population is covered by these three main forms of health insurance, but only 54% of them are covered by their NHI. In world standards, that's pretty low. That's a very low proportion of the population that's covered by their NHI. Now, how does the NHI system work? Well, I could spend the whole day talking about the NHI system because there's so many facets about their system. But I think for our purposes, as we're trying to navigate our own national health insurance and how we are going to implement it, I think there's 3 key things to note about Ghana that I'm going to discuss today. It is their funding, their benefits, and their enrollment. These were things that I think would be of most interest to us. So their funding. There's a 2.5% tax levy on goods and services. Further funding comes from a 2.5% tax on contributions into the Social Security and National Insurance Trust. They also receive further funding from individual premiums, miscellaneous funds. This would be like your investment returns. And then they get financial support from the NHI. The NHI is their National Health Insurance Authority. They are like the regulator of all those 3 insurance schemes. So Treasury pours money into the National Health Insurance Agency, and then they are then responsible for funding the NHI system. Majority of their funds comes from Treasury. About 80 to 90% of the funds come from there. The benefits, let me move over here so you guys can see. The benefits that are offered under the NHI system. So they offer a suite of inpatient and outpatient benefits. Benefit packages can vary across each district. So important point to note about the NHI system in Ghana. It's implemented and administered on a district level. So there's 145 districts in Ghana. Each one of those districts manages, runs, and implements the NHI system independently. So they almost operate on like a silo system. There is, of course, the National Health Insurance Agency that regulates and polices the way that they do it, but each one is administered independently. So there's a minimum set of benefits that each of those 145 districts must offer, but there are supplementary benefits that can vary across each of those. Those supplementary benefits are based on the healthcare needs of the population within the district. So one very unique thing about Ghana, there's no benefit limits, no co-payments, no co-insurance and deductibles. There are other countries in Africa that are trying to implement some sort of an NHI system. There's actually one in Ghana and Rwanda that they have an NHI system. The biggest criticism of all those countries is the excessive co-payments that they are charged, is the very low benefit limits that they have. One of the good successes, one of the reasons why it's so popular, their national health insurance benefits, is that they've got no limits and they've got no co-payments. Another thing that's important to note, they have a compulsory enrollment. So a compulsory enrollment where if you are not enrolled in the two other forms of insurance, they're commercial and they're mutual, it is compulsory that you are enrolled in their NHI system, which is then shocking. Then why is only 70% of the country, covered by it? But they're just having a lot of issues with widening their access to it. But yes, it is compulsory to be enrolled in their NHI system if you're not enrolled in their two other forms of insurance. The premium rates are on a sliding scale. What does this mean? Higher income, people on higher income brackets, they pay more than people that are on lower income brackets. Some groups of the population are exempt from paying premiums. So unemployed individuals, indigent groups, and people under the age of 18 and people over the age of 65 are exempt from paying premiums. What are the successes of Ghana? What are the things that we could learn from Ghana? What has Ghana done so well with its national health insurance? One of the biggest things that they've been able to achieve is a reduced fragmentation within their healthcare system. Second is a massive reduction in out-of-pocket expenditure. When the cash and carry system was around, 55% of expenditure on health was from out of pocket. It's now sitting at the low 30s. So they've managed to reduce the out of pocket expenditure significantly. An equitable benefit package for all members. Doesn't matter if you're on the high income group, the low income group, there's an equitable benefit package for everyone. This is one of their biggest successes. There's been a massive improvements in their disease burden. Throughout the 90s, and also you can say 80s, they were struggling with the burden of disease there. NHI system, through this great benefit package that they have, has been able to control the burden of disease on their population. And one of the most important thing, there's been an overall improvement. Let me move to this side. There's been an overall improvement in the proportion of people that have got access to essential healthcare services, which is what you want to achieve with universal healthcare, of course. Now, what are the challenges? The challenges that they are facing? Well, if you go to Ghana, there's a lot of bad publicity on this. You open a newspaper, chances are one of the front pages, you're going to see people complaining about their national health insurance. So the waiting lines are still incredibly long. Depending what district you are, they're even longer. Supply providers are incredibly frustrated at the fact that they wait 6 to 9 months on average to get reimbursed. So it's not just from users of their healthcare system, but also the providers are incredibly unhappy with the inefficiencies of their national health insurance scheme. Now, what are these inefficiencies? Ooh, I move around too much, eh? But Michael Moore did say you must keep moving, so this is my exercise for the day. One of the biggest issues they're facing is sustainability. So, why I chose to mention this, at the start of them implementing the NHI, it was done in a rush. John Kafu was about to get into power, into president. He was under a lot of pressure to implement this NHI system. There was no proper planning about how this NHI system was going to be funded. And what happened over time, as medical inflation soared, it did not keep up with revenue income. What did this lead to? It led to many of those 145 districts that I mentioned to become bankrupt. There's many of those districts that just don't have funding anymore. Revenue has just not kept up with claims inflation. Another issue that they're experiencing is efficiency. I should have wrote inefficiency there. So I just mentioned that one of their biggest causes to the sustainability issues there is the high excess claims. Huge variable in them having such high excess claims is the lack of cost claims control processes that they have. There's huge areas of fraud, waste, and abuse that are driving up their claims experience. There's also a lack of strategic purchasing, which is again one of the issues on why they're not managing claims and providers so well. Access. Many people don't have access to this national health insurance even though it's compulsory. In many of these districts that I mentioned, they have got a lack of clinics, a lack of hospitals, lack of equipment, lack of staffing. So even though they've got a funding mechanism, on the ground, in each of those districts, they're still suffering from a lack of facilities, which hinders access to essential healthcare services. Governance. There's been a lot of criticism on the regulator. Is the regulator playing a strong enough role in ensuring the sustainability of each of those 145 districts? Is the regulator providing good oversight on their national risk pools? They've been accused of experiencing issues with regards to financial governance and their clinical governance. And probably the biggest one, satisfaction. There's just low levels of satisfaction with regards to this NHI system that they have. Users are unhappy and providers are very unhappy with it. I'm going to move over to Rwanda. Now, the thing is with Rwanda, if you just look at their current metrics right now, you would think that they're not doing well. Like, we've got a higher proportion of people that have got access to essential healthcare services. But for you to see and appreciate the beauty of Rwanda's healthcare system, it's important to know where they started off. Where were they 30 years ago to this day? So I cannot talk to you about Rwanda without going 30 years back into time. How was Rwanda in 1994? One of the biggest atrocities, one of the biggest atrocities in recent memory was the genocide in 1994. This genocide killed approximately more than 800,000 civilians and displaced more than 2 million Rwandans. I'm not going to go too much into the damage into this genocide, but what did it do to their healthcare system? It left their healthcare system in ruins, destroyed their healthcare facilities, led to a lack of doctors and nurses, led to a lack of medicines, medical equipment. There was no money to invest in their healthcare system. Their economy had collapsed in 1994. They were faced with rebuilding a healthcare system post the 1994 genocide. It's very interesting. South Africa in 1994 also had the same choice, rebuilding our healthcare system following the years of apartheid and stuff. So we both, it's quite interesting, just the similarities in terms of in 1994, we both had the same mission, but the trajectory of Ghana and Rwanda is quite shocking in terms of how they've managed to increase access and to improve their healthcare system. And what we have done, it is quite shocking. There's a reason why they're one of the most praised and critically acclaimed countries with regards to how they're dealing with healthcare. How is their healthcare system in Rwanda post the genocide? Post-genocide, they've managed to build a healthcare system that consists of 1,400 healthcare facilities, over 45,000 community healthcare workers, and a robust financing system. There are four main funders of healthcare in Rwanda. You get your community-based health insurance schemes. So this community-based health insurance schemes, this is their NHI. NHI is called different things in different countries in Africa, but this is their NHI here. They've got three other forms of insurance. The Rama, I cannot pronounce this, so I'm just going to leave it at Rama. So this here would be where your public servants are. This is like their gems. They've got a military medical insurance. This is where the military personnel are. And they've got commercial private medical insurance schemes. This is your Liberty Health of the world. Now, close to 90% of the population is covered by health insurance plans. These NHI schemes, this NHI scheme here, covers 85% of the population. So they've got a significantly higher coverage than Ghana, which I just spoke about. It was piloted in 1999, but only formally implemented in 2004. They mostly provide coverage to populations in rural and informal sections of the economy. So how does NHI in Rwanda work? So there's three key things that you should take away from Rwanda. Their funding, structure, and their benefit package. These are three things that we can learn most from. So how is it funded? A lot of their funding comes from individual premiums, government funding, co-payments. So when you go to a healthcare facility in Ghana, you pay around about 500 francs to access services, and then that goes into their risk pooling. Tax revenue from social and health insurance schemes, so that's the tax revenue from those other insurance schemes that I mentioned. Donor funding. 50% of the funding in their national health insurance schemes comes from external aid. 50%. This is during the lifetime of their national health insurance. That there is one of the biggest risks that they face. Because through time, the donor funding, it has reduced, and they're not getting a lot of tax revenue and revenues into the healthcare system, which is one of the issues that are facing. So that there is one of their biggest risks. And another source of funding is miscellaneous funds, which is various other things. Their benefit package, they offer a suite of inpatient and outpatient benefits, curative and preventative benefits. Cover is only provided at public facilities. They don't have a lot of private facilities, so this is not so much of a big issue. I think only 10% of their facilities are private facilities, but private facilities are excluded, and for-profit facilities. Their structure, so very, very similar to Ghana. These national health insurance schemes, community-based health insurance schemes, they're implemented on a district level in a decentralized manner, identical to how Ghana does it. And membership here is compulsory if you are not registered under their other 3 insurance schemes. What are the successes of Rwanda? Massive reduction in out-of-pocket expenditure, improved life expectancy. If you guys ever have time, you should go on Our World Data and see how their life expectancy has increased dramatically since that 1994 genocide. And their healthcare system has been a big factor in it. They've achieved all their health-related millennial goals. They're one of the few African countries that can lay a claim to this. It's because of this healthcare system. These millennial goals are they've achieved a reduction in child mortality, reduction in maternal mortality, and improvements in disease burden. And the most important thing, they've increased coverage of essential healthcare services, because this is what universal healthcare coverage wants to achieve. This picture right here. So, So the challenges that Rwanda is facing, yes, they have seen improvements in the proportion in their universal healthcare coverage, but they're still significantly far off from the rest of the world, and they're trying to achieve world standards. So what are the challenges that they're facing? The benefit package. The citizens of Rwanda, although they are happy with how far they've come, they're not happy with the benefit package. It's not keeping in line with the changing disease burdens within the country. It has fallen behind. It has not improved and been enhanced over the 20, 30-year period, 30-year period. Governance. They suffer from similar governance issues that Rwanda's facing. That's lack of involvement from the regulator. Lack of oversight on their national risk pools, which is one of the reasons why many of the districts are bankrupt as we stand. Sustainability, similar issue to what Ghana's facing, where the revenue into their national health insurance schemes is not keeping up with the increase in medical costs, which is resulting in a lot of the districts being bankrupt. Supply side issues. Recently, this is a post-pandemic issue, massive levels of fraud, waste, and abuse that's crippling their resources. And access. They're having huge issues with access to healthcare within their rural communities. Fine, they've got a funding system, but they still have got districts and provinces that are suffering from lack of medical facilities, lack of medical personnel. So even though they've got a funding system, they just in the provider space, it's still quite lacking. But I don't want to end Rwanda on a good note, because I want Rwanda to be a country that we can learn from, that we can aspire to. This is my favorite quote in Rwanda. Rwanda is an example of how a country can rise from the ashes of a genocide to be a model for social development globally. This is how far Rwanda has come from 1994 to where it is today. In a 30-year period, they've managed to achieve this. Okay, I'm running slightly out of time, but I'm going to be done now, guys. Now, why am I telling you all these things? Why am I telling you things about countries so far away? It's because there's lessons we can learn from our neighbors. The struggles, the successes that they faced, there's things we can take away from them as we are busy trying to implement our own NHI system. What have they done wrong? What have they done right? What can we learn? Lessons we can take from Rwanda and Ghana. You cannot implement national health insurance without strong leadership, without political commitment. As different presidents and different parties were coming into power, one thing remained constant: trying to achieve universal healthcare coverage. The policies, the aims were all consistent, and that was trying to achieve some sort of universal healthcare coverage. So you need strong leadership at both a national and a district level. Collaboration. What Rwanda has done so well is that all parties of the healthcare system were pulling in one direction in trying to achieve universal healthcare coverage. People from the private sector, people from the public sector, everyone was pulling in one direction in achieving this one aim. That's one thing that they've done so well in Rwanda, and one big thing we can learn from. Sustainability. As you saw there, a common theme amongst Rwanda and in Ghana is that a lot of the districts that were responsible for implementing NHI, they were suffering from sustainability issues. Many of those districts, they are bankrupt. The revenue into their national health insurance schemes has not kept up with claims inflation. And another one, governance. That was a key theme across both countries. They're struggling with governance issues. And the biggest thing that we can learn from these two countries is that it takes time to build a national health insurance system. Rome is not built in one day. If you can't build Rome in one day, you cannot build a national health insurance scheme in one day. It takes time. These countries, it took them 2 decades to be where they are now, and they're still struggling. They're still having issues. So this is not going to be an overnight process. Now, as I'm going to leave, I'm going to leave you guys with these parting words. This is one of my idols. Whenever I'm confused and I need some sort of direction, I just pull up a Nelson Mandela quote. And he's got a very beautiful quote on healthcare that we should all keep in mind when we're having engagements and conversations with regards to NHI and what we can do to achieve universal healthcare coverage. No matter what the issue is, no matter what the challenge is, no matter what the circumstances, one thing is always true: health cannot, must not, shall not be a question of income. It is a fundamental human right that we all deserve. Thank you very much, ladies and gentlemen.
Thank you.